All right, listener, welcome back. Today, we're doing a really focused deep dive, specifically aimed at helping you if you're prepping for the MSRA exam. We're zoning in on fungal nail infections, or onychomycosis, as it's properly called. We've pulled all the key stuff from the sources you shared, ready to unpack it. So the plan is to boil onychomycosis down to the absolute must-know points. We'll hit definition, causes, diagnosis, management, complications, the whole lot. Think of it as a quick, high-yield revision boost.
Absolutely. And it's worth saying, this isn't just exam fodder. Onychomycosis is super common in practice. You'll see it a lot, especially with, older patients or those with diabetes. So getting a good handle on it now is genuinely useful for your future clinical work too.
Great point. Okay, let's dive straight in then. What is onychomycosis, basically?
Fundamentally, it's just a fungal infection of the nail unit. Simple as that. It can be fingernails, but honestly, it's much, much more common in toenails.
Okay, and what does it actually look like if a patient walks in?
Well, you'll see pretty obvious changes. The nail usually gets discolored, often turns kind of yellow or brown, sometimes white, and it gets thicker, typically. The texture changes, too. It might become really brittle or crumbly, almost chalky.
Right, so it's not just about how it looks. People sometimes think it's purely cosmetic, don't they?
Yeah, that's a really common thought. But no, while the appearance is, often why people come in, they don't like how it looks, it can definitely cause actual pain or discomfort. It can lead to disfigurement of the nail and sometimes functional problems like difficulty walking or fitting shoes properly. And it can impact quality of life too, maybe due to embarrassment or stopping people doing things like swimming.
Okay, got it. So it's fungus causing these changes. But what kind of fungus? Is it always the same one?
No, not always. The main group responsible are dermatophytes. And within that group, one called Trichophyton rubrum is, well, it's the most common culprit by far. But you can also get it from yeasts, particularly Candida albicans and even some non-dermatophyte molds.
Molds, really?
Yeah, though they're less common. You tend to see those more in people who are immunocompromised, like Scopiorrheopsis brevicollis sometimes pops up in patients with HIV, for example.
That's really interesting. So you can't just glance at a dodgy-looking nail and know exactly which bug is causing the trouble.
Exactly. The clinical picture can look pretty similar regardless of the organism. And that's why often getting lab confirmation, figuring out the specific fungus, is quite important for choosing the right treatment.
Ah, okay. That makes sense. Treatment depends on the bug. So who's most likely to get this? Who's most at risk?
Well, there's several things that increase the risk. Advanced age is a big one. It gets much more common over 60. Also, having a weakened immune system. That could be from illness or medications like steroids or chemotherapy. And diabetes mellitus, especially type 2, is a major, major risk factor.
What about lifestyle stuff? Or the environment?
Oh, definitely. Having athlete's foot tinea pedis already is a huge risk. The fungus basically just spreads from the skin onto the nail. Easy target. Warm, humid climates also help fungi thrive. And repeated trauma to the nail, even minor stuff from tight shoes or sports, can kind of open the door for the fungus to get in. Other things the sources mention, peripheral vascular disease, poor circulation basically, jobs where your hands or feet are wet a lot, poor nail hygiene, sharing things like nail clippers or towels, and using communal showers or swimming pools, wearing those tight, non-breathable shoes all day. All that increases risk.
Wow, quite a list. Trying to remember all those for revision. Maybe a mnemonic could help. Someone suggested old times. Does that work?
Old times. Let's see.
Oh.
O for older age.
Huh.
Yeah. L for lifestyle, like sports, communal bathing. D for diabetes. T for trauma. I for immunity compromised. M for moist environment. E for existing skin infections, like tinea pedis. And S for shared items or maybe systemic disease.
Yeah.
That actually works quite well. Old times. Good one. Covers most of the key bases.
Cool. So old times for risk factors. Okay, we know what it is, who gets it. How does the fungus actually, invade the nail and cause all that thickening and crumbling? What's the pathophysiology?
It usually starts with direct contact. So, picking up fungal spores from, say, a contaminated floor or shared clippers.
Yeah.
Or, as we said, really commonly, it just spreads from nearby infected skin, like athlete's foot crawling onto the nail. Once the fungus gets under the nail edge, or into a little crack.
It finds a nice home.
Pretty much. It gets into the nail plate, the keratin structure. It's protected there. It's moist. And it starts to multiply and spread within the nail itself. And it's that invasion and multiplication, plus the nail reacting to it, that causes all those changes we see, the thickening, the discoloration, the brittleness.
Right. So thinking clinically again, patient comes in, thick yellow toenail. Is it always going to be fungus? Or are there other things that look similar?
This is a really, really important point, especially for exams. The answer is definitely no. It's not always fungus. You have to think about differential diagnoses. Lots of things can mimic onychomycosis.
Okay, like what are the main mimics?
Well, top of the list probably is nail psoriasis. It can look almost identical sometimes. Lichen planus is another inflammatory condition that can affect nails. Trauma, especially chronic repeated minor trauma, can cause thickening and yellowing over time. And you can get bacterial infections too, though they often look a bit different, maybe more inflamed around the edge.
What about just weird-looking nails from other causes?
Yeah, absolutely. There's something called onychomycosis, those really thick, curved ram's horn nails, often in older people, usually from trauma or neglect. Just general poor foot care can make nails less damaged. Eczema around the nail can sometimes cause changes. And crucially, you need to think about serious stuff. Subungual melanoma skin cancer under the nail can look like a dark streak or patch. You cannot miss that.
Definitely not.
Psoriatic nail disease, we mentioned super common differential. Bacterial paronychia infection around the nail fold, especially Pseudomonas, can cause a greenish color. And then think systemic. Thyroid problems, diabetes again, poor circulation, even some rare things like yellow nail syndrome or reactions to medications. The list is quite long.
Okay, that's vital to remember. Let's try a quick scenario, MSRA style. Patient has a thick, crumbly toenail, but you also notice silvery scales on their elbows. What differential jumps out?
Psoriasis, straight away. The nail might look fungal, but those skin lesions elsewhere are a massive clue for psoriatic nail disease.
Okay, another one. Patient on chemo develops a thick, painful nail, bit red and swollen around the edge, maybe a slightly green color under the nail.
Right. Well, chemo means immunocompromised, so higher risk of any infection, including fungal. But the pain, the redness, the swelling, the paronychia, and especially that green hint, makes you think strongly about a bacterial cause, probably Pseudomonas.
So it could be both?
Could potentially be both, or primarily bacterial superimposed on a damaged nail. You'd need to investigate carefully.
Great examples. So how common is onychomycosis? What's the epidemiology look like in the UK?
It's pretty common. The sources suggest somewhere around 4 to 8% of the UK population have it. And like we said, it's way more frequent as people get older and in those risk groups like diabetics. And the numbers seem to be increasing, actually.
Why is that?
Likely due to, well, more diabetes, more people living longer with weakened immune systems for various reasons, and just the population aging overall.
Right. Okay, let's recap the clinical features. What are the absolute key signs you look for?
The big ones are the nail discoloration, yellow, brown, white, the thickening hypertrophy, and that crumbly, brittle texture. The nail shape can get distorted too, and you often see onychomycosis. That's where the nail plate lifts up and separates from the nail bed underneath.
Does it always hurt?
Not always. Some people report pain or discomfort, especially if it's really thick, but often the main complaint is just that it looks, unsightly.
You mentioned different fungi. Are there different patterns of infection too, like how it spreads?
Yes, that's another useful distinction. The sources describe a few main clinical subtypes based on the pattern of invasion. The most common is distal and lateral subungual onychomycosis, DLSO. That starts at the far end, distal, or the side lateral of the nail, and spreads inwards underneath the nail plate. Classic toenail pattern, usually dermatophytes.
Okay.
Then there's superficial white onychomycosis, SWO. Less common. This one looks different. It's like white chalky patches right on the surface of the nail. You can sometimes scrape it off.
Right.
Then proximal subungual onychomycosis, PSO. This starts near the cuticle at the base proximal end and grows out. Less common again, sometimes seen with Candida, can affect fingernails more often than DLSO.
Okay, and the last one?
That's total dystrophic onychomycosis, TDO, basically the end stage. The whole nail is thick, crumbly, discolored, destroyed. If you see that, you definitely need lab confirmation before you treat.
Quick check then. Patient has a white patch just on the top surface of the toenail. What type?
Sounds like SWO superficial white.
And a completely wrecked, thick, crumbling toenail that's lifting off.
That's TDO, total dystrophic, end stage picture.
Perfect. So we suspect it, we see the signs. How do we confirm it's fungus? You said appearance isn't enough.
Absolutely. Clinical suspicion gets you started, but ideally, especially if you're planning treatment, you want lab confirmation. Treatments aren't trivial, they take time, can have side effects.
So what tests do we do? Send off nail clippings?
Exactly. You need to collect a sample, nail clippings, or scrapings of the crumbly stuff from under the nail. send that to the lab. They'll typically do microscopy look directly for fungal bits under the microscope and culture, trying to grow the fungus to identify it. PCR is sometimes used too. It's more sensitive for dermatophytes, but maybe not standard everywhere yet.
Okay, now this next bit seems really important for MSRA interpreting those results. It's not always straightforward, is it?
No, the criteria differ slightly. This is definitely high yield. For dermatophytes, if either microscopy or culture is positive, that's enough. Confirmed.
Okay, either for dermatophytes.
For Candida, you need both microscopy and culture to be positive to say it's definitely Candida causing the nail problem.
Both for Candida.
Wow.
And for those non-dermatophyte roles, stricter still. You need both microscopy and culture positive, and ideally on 2 separate samples taken at different times. That's to be sure it's a real infection and not just contamination from the environment.
Wow. Okay, that's quite specific. Any tips for getting a good sample?
Yeah, good point. Try to get the sample from the most proximal part of the affected area, so closer to the nail bed, deeper under the nail if possible. That's where the fungus is likely most active. And send plenty of material if you can. Don't just send a tiny clipping.
Makes sense. More sample, better chance. Okay, diagnosis confirmed by the lab. Now what? How do we treat it?
Right, treatment. First question, actually, is do we need to treat? If it's totally asymptomatic, not bothering the patient functionally or cosmetically, and they don't want treatment, then, well, watchful waiting is an option. No treatment needed.
Okay. But assuming we do treat, then step 0, as we said, is confirm the diagnosis with microbiology first. Absolutely crucial. Don't treat blind.
Right. Diagnosis confirmed. What's the usual plan, especially for the common dermatophyte type?
For dermatophyte infections, first line is usually oral terbinafine, and the durations are key exam knowledge. For fingernails, it's typically 6 weeks up to 3 months. For toenails, it's longer, 3 months up to 6 months.
6 months, wow.
Yeah, toenails grow slowly, fungus is stubborn. Oral itraconazole is an alternative if terbinafine isn't suitable.
And what if it's Candida?
For Candida, if it's mild, maybe just topical antifungals like Amrylfine nail lacquer. But for more significant Candida nail infection, you'd probably use oral itraconazole, often for about 12 weeks.
What about just using the topicals, the lacquers, on their own?
Topicals definitely have a role. They can work for very mild cases or that SWO type where someone really can't take oral meds. But the big but is they take a long time, 6 to 9 months for fingernails, maybe a year, or even more for toenails. And cure rates might be lower for anything more than mild disease.
So if topicals fail or aren't suitable?
Then you're looking at systemic oral treatment. We mentioned terbinafine, continuous itraconazole. There's also pulsed itraconazole, taking it for a week each month. Griseofulvin is another older oral option, takes even longer though. And fluconazole sometimes.
Are there major downsides to the oral pills? Side effects?
Yes, you need to be aware. They can cause things like headache, tummy upset, rash, fatigue. The main thing providers worry about is potential liver problems. Those serious issues are rare with terbinafine. Liver function tests are sometimes monitored, especially for longer courses or with itraconazole. It depends on the specific drug and patient factors.
Any other treatments? Surgery? Lasers?
As I mentioned, nail removal avulsions, sometimes combined with antifungals, chemical debridement. Laser therapy is around, but the evidence is still evolving for some of these newer methods.
When should we think about referring someone on?
Good question. Refer if the diagnosis is still unclear after tests, if they're failing standard treatment, if they might need surgery, if you suspect an underlying immune problem, if it's really extensive, or they keep getting recurrent Candida infections.
And what can patients do themselves?
Self-care helps a lot. Keep nails trimmed short. Good foot hygiene, wash and dry thoroughly. Wear breathable shoes, cotton socks. Avoid trauma. A chiropodist or podiatrist can be brilliant for managing thick nails, even just for comfort and appearance. Treating it also helps reduce spreading it in places like pools. Oh, and just a note, it's much rarer in kids, and treatment choices are more limited for them.
Let's just quickly repeat those terbinafine durations again. They feel important.
Definitely. Oral terbinafine. 6 weeks to 3 months for fingers, and 3 to 6 months for toes. Remember, toes take longer.
Got it. So after potentially 6 months of pills, what's the outcome? What's the prognosis like?
It really varies. Success depends on how bad it was to start with, the type of fungus, how well the treatment works for that person, and their general health diabetes. Circulation issues make it harder. Many cases can be cured, but it's not 100%. The source's, quote, mycotic cure rates, meaning fungus, eradicated for oral terbinafine, around maybe 76%. Itraconazole a bit lower, maybe 60-ish%. Fluconazole lower again.
And does the nail look instantly better once the fungus is gone?
Ah, no. That's a key expectation to manage. The clinical appearance only improves as the new, healthy nail grows out from the base. That takes months. So even after a mycotic cure, the nail might still look damaged for quite a while until it fully grows out. Fingernails usually do better and faster than toenails, and if you don't treat it, it'll likely just get worse over time, potentially destroying the whole nail plate. Prevention. Well, primary prevention isn't usually a big focus unless someone's high risk. But secondary prevention, stopping it coming back, is important. Using antifungal cream after oral treatment sometimes helps, and all those hygiene things, dry feet, treating athlete's footwear in communal areas.
Okay, finally then, the complications. What can go wrong if this isn't managed?
It's more than just looking bad. You can get permanent nail disfigurement or total nail loss. Infection can spread to the surrounding skin, that's paronychia. But the really critical thing, especially for vulnerable patients like older adults or diabetics, is that the damaged nail acts as an entry point for bacteria.
Leading to worse things.
Potentially, yes. It significantly increases the risk of bacterial cellulitis in the foot or leg. That can lead to osteomyelitis, bone infection, or even sepsis in rare severe cases. It's a major factor in diabetic foot complications. And don't forget the psychosocial side. The embarrassment, stigma, avoiding activities. Plus, pain and discomfort can genuinely affect mobility and function, particularly in the elderly.
Okay, so wrapping this up, we've covered a lot of ground on onychomycosis. From what it is, the different causes, those old times risk factors, through the mimics remembering psoriasis, the importance of lab confirmation with those specific rules, the treatment options like terbinafine and those crucial durations, right up to prognosis and the potentially serious complications, especially for diabetics.
Yeah, and I think the key takeaways for MSRA prep are really understanding those differential diagnoses, knowing why and how you confirm the diagnosis before treating, and being familiar with first-line treatments like terbinafine and their durations, plus always considering the implications for higher-risk patients.
It definitely shows how even something that seems quite common needs a really thorough, systematic approach. Good stuff to keep banked for revision. For more free MSRA revision resources, do visit freemsra.com, and for the full premium revision toolkit, head over to pastthemsra.com.